If you have never used Teams before, if you move your mouse, a toolbar will come up in front of your face, and those are going to be how you control where you're at today. So if you want your video off, you'll push the video little recorder there looking thing, and that will turn off your video. And if you push the little microphone, same thing, you'll go mute. If you push the comment bubble looking thing, then a whole little list of comments are going to come up on the right hand side of your screen. That's where you'll be able to add comments, ask questions. Unfortunately today, because there's so many speakers, which is a good problem to have, I think I did mention that we are going to have to wait probably until the end for questions. So let's do that, but maybe even plunk them in the comments section just so we remember that they're out there so we don't forget them. That's okay to do for sure. And so the one thing that I do want to say before we get started with the NIATEX, I just want to remind you, I don't know if any of you have missed the jingle in July, the curbside jingle in July that happened at the very end of July. We're having a little pop-up jingle. You might have seen that in the Constant Contact. That's going to be November 3rd. Ooh, I'm echoing. November 3rd from 2 to 4 at St. Charles. And if you haven't been to St. Charles, this is the one on 84th Street. The one on 76th Street doesn't exist anymore. And so it's 151 South 84th Street. Make sure you mute yourself.
Well, when we're in Teams.
Oh, I've got somebody that is on. Make sure you mute yourself. And so it's building number 5. When you're on 84th Street there, it's the closest building to the street. And so just pop on in. We'll be there at the front desk. We'll have t-shirts that are still available to you, and also the swag bags we have left too from that event. So 2 to 4, November 3rd, and I'll be sure to get some more details out that on our listserv too, so that you don't miss it, okay? So there's that. I just wanted to put that out there. And then the one thing I wanted to say about the NIATEX Storyboard Marketplace is that Janet and I have been doing this for a long time. And the little bit that I wanted to say about it was that years ago when I was hired, I'm Amy Amabius, by the way. If you do not know who I am, welcome. I am the best practice coordinator at Community Access to Recovery Services. One of the things I do is help coordinate these MC3 meetings. But another thing that I do is I'm Janet's partner in crime with these NIATEX collaboratives. And so at the end of the year, we try to put together a storyboard marketplace where people can really talk about the continuous quality improvement projects that are happening within their agencies. And so years ago, when I was hired, people really liked MC3. They're like, cool values, yay, a co-occurring system, yay, an awesome tool to find out where we need to get started, the compass easy, yay. Okay, now how do we do that? And so that's when MC3 got married to NIATEX. And so this is where I'm going to hand it off to Janet to talk a little bit about NIATEX. And then Janet's going to hand it off to the next person. And then we're going to hear some really awesome quality improvement projects today that are happening throughout our system, and it's going to be a really great day. Go ahead, Janet.
Okay, Amy, thank you. Thank you. Welcome again to everybody. So I'm Janet. I work alongside with Amy. I'm also with CARS, with BHD CARS, Community Access to Recovery Services. And Amy took everything that I was going to say. She said I had 2 to 3 minutes max, which anybody who knows me, 2 to 3 minutes is like me taking a breath, okay? I can't even. But thanks, Amy, for taking my show. So I'm going to edit myself on the fly. And Shirley, that's my dog, by the way, but she's very excited about this too. But seriously, I could be more excited. And, this is our first time doing our storyboard marketplace. and virtually. So one, it's kind of weird, but I love seeing people. I love that. I love Pam has SpongeBob. I'm seeing Tamra, I'm seeing Pat, I'm seeing all these wonderful, beautiful faces. And I think there's about 100+ people out there. So you guys, thank you so much. I actually was at the office today and sort of had this, feeling, because we were going to do this marketplace this afternoon. So this is about having fun. Like Amy said, we've been doing this a long time. I've actually been participating in NIATEX and continuous quality improvement since my tenure with the county, which is 16+ years right now. And Amy sent a great constant contact email, which did provide a brief description of NIATEX. But really what is cool about the NIATEX process improvement model is it's intentionally meant to be simple, meaning as professionals in the field of behavioral health, the more time we spend with people, the better. We don't always have the time to spend on data and learning different, data methods and learning about SPSS and things like that. So NIATEX truly is, it's a brief process improvement model that's really founded on the PDSA cycle, which is the plan, do, study, act. And you can do as many of those as you want. You can do one, depending on whatever your aim and change project is. Our very first project was probably 16+ years ago. And it was a project that I had the privilege of working on with a colleague, Jenna, who, as many of you may know, Jenna DeSosa. And it was called We Want You. And it had to do with increasing provider participation in our meetings. And I don't know how other people feel, but I would say, here we are, even, I don't know, at least what I can see on Teams, there's over 120 people. So I think we've been successful. And the other cool thing is that CARS also approaches NIATEX from a systems a level. And we're actually going to probably soon be doing some announcements. I don't want to say anything. Jen might get mad at me if I blow the surprise, but we're going to be looking at doing a new systemic NIATEX project. And you guys, seriously, it's going to be really important and I think very special. And then the other thing is that we have since done is we have monthly collaboratives. And I wanted to say, before I do my handoff to the Michelles, is I am going to say this, and everybody believe me, okay? This is our 16th annual storyboard marketplace. And so I think everybody either clap and or use your clapping hands. I think it's a huge testimony really to the community, to our providers. You guys are all amazing and I can't wait. And yes, Amy, I know I'm way over, so I'm turning it over to the Michelles.
Good afternoon, everybody. I am one of the Michelles. I'm Michelle Corbett. I am here with Michelle Bunyer at her house. And we're coming to you from the Center for Urban Population Health, which is a collaborative partnership between UW-Madison, UW-Milwaukee, and Advocate Aurora. And our role with the NIATEX Collaborative is now, I think we've been participating with you guys for 3 years, maybe 4 years. COVID kind of messes time up for me. And if you want to actually show our slides, that would be great, Amy. Sorry, because yeah, it'll take us through really quick. But basically, our role with the collaborative initially was to help evaluate the collaborative. As Amy and Janet have said, it's been around for a lot of years, but it hadn't actually been systematically evaluated in terms of outcomes and what benefits are coming out of it. And so we were kind of brought on to help with that. But since that time, we've also evolved into, got a message, co-facilitating the monthly meetings. We're gathering data on process, how are meetings going? How are they meeting people's needs, as well as outcomes? And I'll show you a few outcomes in just a second. We're using that data because we're collecting it on a regular basis to help support ongoing improvement of the collaborative to ensure that it's meeting people's needs. And for anyone who's participated in it for more than just a couple months can pretty much see kind of rapidly how changes are implemented in response to the feedback that we get from participants. And then we also, Michelle and I, provide one-on-one support and technical assistance to participants as needed. We're here as an additional resource on top of Amy and Janet. So that's who we are. If you want to change, go to the next slide. So this is a word cloud for our May 2021 meeting in terms of how participants at that meeting, okay, Janet, she's excited, would describe the meeting. So we typically ask, how would you describe the meeting in one word? And just to give you a sense, informational, that particular meeting was the most commonly cited single word. But you can see some of the others: motivating, inspiring, resourceful, enlightening, positive, energizing. And so Janet and Amy, along with all the participants, have really cultivated a space for those in the audience who've never been to a NITEX meeting. That's who I'm kind of talking to right now. Have really cultivated a space that is supportive, that allows peers to I was going to say support each other as they go through this process of making improvements within their own programs and agencies. So it's really exciting for us to be a part of that. Next slide.
You got a cost picture.
So then, whoops, someone's unmuted. So we also ask at the end of every meeting, what makes collaborative meetings worth attending for folks? And we also ask, what can we do to improve? But I just, again, for those folks who maybe have never been to a NITEX meeting, what are people getting out of it? And so I'm not going to read all of these, but there is one in particular, that yellow one, that I love. And these were from these are just from feedback we've gotten over the course of this year, which has all been virtual. But hearing others' experience with their projects and being able to provide support to each other as we further develop our projects and run into bumps in the road. So this group is pretty amazing. Lots of feedback, lots of encouragement, and you're going to see the result of that support in today's presentations. I do just one more slide here, because as I mentioned, we're not only looking at kind of process the day-to-day of these meetings and how things are going, but are they achieving the outcomes that the NITEX Collaborative has for itself? And so you can kind of see on the left-hand side of this chart are a bunch of statements, and these are kind of the outcomes that we're hoping for of participation over time with the collaborative. And this is from our 2019 annual participant survey. Since last year, we really didn't have meetings. We didn't do one last year, but heads up for those who participated this year, you're going to get an invite to do this year's survey. But as you can see, the overwhelming majority, actually the majority of, for all of these statements, except for that very last one, folks agreed with in terms of because of collaborative participation, increase the knowledge and their skills in order to engage in quality improvement and process improvement, as well as, sort of increase their interest in it. And they're more aware of what's out there and available just in terms of services for their consumers. So you can go ahead and close. That was the end of the slides. But just wanted to say that the collaborative, if you've never been, please, please, please consider joining us next year. And I think at the end, you'll probably make mention about what the plans are for that. But yeah, let's hand it off, obviously, to hear all of these wonderful projects. I know that's why folks are here today. So thank you so much.
It looks like it looks like someone pushed record. So thank you for that. And then also, I think now that we're going into everybody's presentations, let's go ahead and turn off our videos so that the people that are presenting can just have their screens on, and then make sure please to mute as well. And so the first presentation that I have today is JFS and building a better community. Kevin, are you on now? Would you like me to share your presentation?
Actually, Shelby will.
Yeah, actually, yeah, Amy, I'm gonna share. I'll just share my screen.
You're going to share your screen. Okay.
Yep.
Then I'm going to duck out.
Sounds good. All right. So hello, everyone. My name is Shelby Gwendell, and I am the Community Programs Coordinator at Jewish Family Services. So our NIATEX project is called Building a Better Community, a review of the annual Bradley Crossing Resident Satisfaction Survey. And this was actually a 2-cycle project where the first cycle we analyzed previous surveys and created a new survey and distribution methodology. And then the second cycle was to actually then implement that survey and do the data analysis of that. So an annual satisfaction survey was completed for Bradley Crossing residents before 2020, but it was actually distributed and analyzed by a third party. So we really wanted to bring that survey back in-house. So we had much more control over the surveying and the data analysis. So our aim was to create a survey to offer a validated measure of resident satisfaction of community integration with a goal of 50 responses by March 30th, 2021. So the baseline for the survey responses from the 2019 was 57 responses. So we thought that it was a really realistic goal to have 50 responses for the past year's survey. So our measures used, the survey was 20 questions, both quantitative and qualitative questions. And it was written in English and was distributed via 3 methods. We used paper copies, which were then able to be dropped back off via a Dropbox. We also had an online survey via SurveyMonkey, or for individuals that needed assistance, we could do those over the phone. And we did have some sort of enticement. So in the 2019 survey, every participant was able to receive a t-shirt. For last year's, though, we decided that we were going to do a raffle drawing. So participants could put their name into a drawing. And even though we said that their names would not be used for data analysis, that was still somewhat of a worry for folks, even though their names were kept off of the data analysis piece. And so some questions from the survey included measuring of belongingness, knowing their way around the community, knowing the rules, acceptance, independence, feeling close to others, having useful or productive activities to do, changes, whether they be for better or worse, stress management, knowledge of community resources or assistance programs, and then also children participation. So these were our results. So 51 responses of the 112 total households left us with just above a 45% response rate for the entire population. So we did meet our goal of achieving 50 survey responses. And the data analysis showed that Bradley Crossing is good at providing a space where residents can feel independent, comfortable and confident in the community, but also knowing that they can reach out to staff to assist them with accessing community resources or any other assistance programs if needed. But some things that we have to improve upon is the actual sense of community. So less residents felt like they belonged in the community and that they were able to participate in activities that were useful and productive. And other concerns noted were the upkeep and maintenance of buildings, as well as the noise level and supervision of children that live there. And then when comparing that to the 2019 data, there was a decrease in the reported sense of belonging at Bradley Crossing. There was an increase in the satisfaction with staff, and there were no changes related to the reported sense of independence. So through this project, what are we going to adapt, change, or reject? So we're choosing to adopt the new survey and methodology that was created for the 2020 survey. We not only met our respondent goal, but we also were able to maintain COVID-19 safety guidelines during distribution. And the survey enticement may need to be adapted based on the budget to determine which is more feasible, whether we do a raffle or if all participants are able to get something. And lastly, we need to adapt the survey distribution and engagement to include more respondents from outer buildings. So Bradley Crossing contains separate apartment buildings within the same community. And One of the buildings is the main building, so it has, staff offices, it has a community room, it has the Dropbox location for the survey, and we noticed that 61% of the respondents from the 2020 survey actually lived within that main building, and so we really need to engage the outer buildings to make sure that their voices are being heard as well. And then these are just actually some recommendations that we found from the data. So in addition to making those survey logistic changes, there are some recommendations that we put forward as well based on the findings. And so there needs to be an increased sense of belonging, programs for residents and ways in which residents can gather that feels useful and productive. There needs to be an increase in communication about standards related to noise and supervision of children. And there needs to be an increase in upkeep and maintenance of buildings. And there are some ideas listed there that our interns came up with when doing the data analysis. And that is all I have. Thank you so much.
Wonderful. Thank you so much. That was just great. Yes, I see a lot of hands clapping. Remember, if you do have questions, to go ahead and put them in the chat. And if we have time at the very, very end of this change agent meeting, we'll make sure that people have their questions answered. We might be able to stay a little bit longer too, depending on if the speakers are able to stay longer. But we have about 29 people to get through. So I just want to make sure that everybody gets their time today. So we will move on. I have the next project called Hot in Here, and it's Guest House. Andrea, are you ready?
Entire screen.
Do you need me to share?
I should be. Am I sharing now?
I do not see anything.
Sorry. Why don't you go ahead and share, just because I don't want to cause delays.
All right. Let me get my.
Fabulous. Thank you. Okay, so my name is Andrea Peterson. I am from the Guest House of Milwaukee. Our title is Hot in Here, and our interest was increasing the frequency of the Wisconsin Recovery Thermometer implementation among our care coordination team. Next slide, please. Amy, can you get the next slide up? Fabulous. Then our change team is our care coordinators, our CCS supervisor, the mental health professionals, the substance abuse professionals, the QA auditor, and CCS director. Next slide. The aim of the project, again, was to increase the frequency of the Wisconsin Recovery Thermometer, also known as WIRT, implementation by our care coordination team, as documented in Provider Connect. And our actual data source was the progress notes themselves that are written and stored in the system. Next slide. After identifying our item that we wanted to change, we consulted with the team, asking them how they think they could make a single small change that would make it easier for them to ensure that the tool was implemented every 4 to 8 weeks. The team themselves identified that a tracking tool would be useful, and one of the staff already had one in place. That information was shared with the team. They agreed upon it. So each member of the care coordination team adopted a tracking for their caseload in the month of March. They were trained on how to use that, and then it was implemented effective April 1st. Our target was to increase the implementation of the tool as documented by Case Note in Provider Connect from approximately 25% to 75%. Next slide. Here you'll see our pre-test and post-test results. With our pre-test, we were approximately 48% of our consumers had a WIRT within 4 to 8 weeks. After implementation of our tickler process, we were able to increase it to 62%. Next slide. And then again, a 14% improvement was made. Unfortunately, the goal itself of an increase of 25% wasn't met. We discussed the results with the team, and we agreed that the project was important, and because we did see improvements, that we should continue. We decided to adapt based on the conversation. A particular staff member happened to mention that they were successful because following the tickler, they took the additional step of adding the information to their calendar. So as part of our ADAPT program, we have encouraged all of our care coordinators to take the tickler information and add that to their calendars to help them manage the timeliness requirements. Next slide. A couple of notes should be made about the evaluation of our project. We did have a number of data confounds that we couldn't control for, which included staff turnover, staff vacancies. For some reason, we had a staff with a significant delay in implementation. All the staff relocated to a new location during the evaluation period. We also found that we had some important delays when it related to discharging consumers that simply were not engaging with us. And then staff reported there was an increase in consumer cancellations. However, the project is very sustainable. We have already hired and trained new staff since we implemented this process. We are setting accountability. I believe this is actually a part of their performance indicators for the next employee review period. And we are more aggressively identifying consumers to discharge if they have not successfully engaged with care coordinators. The sustainability process will be continuing with sustained leader monitoring and evaluation as all part of the program's management team. And that is what we have from the Guest House of Milwaukee. Thank you.
Sorry about that. I had a hard time getting back to you guys. Okay, so next we move on. And let's see, we did Penny for Your Thoughts, and now we're moving on to Bricks and Mortar by the TCM providers. I believe that's.
We didn't do Penny. We still need to do a Penny for Your Thoughts.
Oh, yes, Barbara. Yes, I got you. Thank you so much. Thank you. You guys got to keep me on track today. Okay, thank you. All right. And you need me to share the screen?
Yes, I do.
All right. Let me see if I can do that for you. I know that you sent one today. Let's try this one. Oops. Let's try this one. Let's see if we can get this one to advance. Can you see that one okay?
Yes.
Okay. Go ahead when you're ready.
Okay. Hi, everybody. I'm Barb Pickestar. I'm working with La Causa in the Recovery Support Coordination Program. And I started out this project as a one-man team, but I eventually added my lead RSC, Elizabeth Belling. So I just wanted to put her name out there and thank her for her assistance with the slide presentation. The name of our project was A Penny for Your Thoughts. It was based on surveys that we received of clients' names in our program. We received a list of clients every month from CARS. And we were to have those surveys completed by our clients. You can go to the next page, Amy.
It doesn't want to go. I'm not sure why. Let's try. Oh, it doesn't want to.
You could try going back to the first one if you like. I mean, it was fine. I had just made a few edits to it.
Let's see. Let's go into here and just see if it would be in here. All right. Try that. Is that better?
Yes. So we decided that a survey would be important because it tracks the experiences of the clients who are in our RSC program. The surveys help us make positive changes within our program to better serve our clients. It allows us to track the overall success of our program, and it also allows for our clients to feel like they're being heard. Next slide.
Fortunately, this one does not want to go either. Well, let's try this and see if it will. Maybe I'm just buffering. Yeah, I think I'm frozen actually, because now it won't even let me escape out of here. Let me just try this once. Let's see if it will let me do it. There we go.
So our baseline, we started the project in February of this year and we ran it for approximately 6 months. Based on our populations we serve, we needed to complete approximately 41 surveys within the 6-month period. And we had completed only 3 surveys by the end of February. So we wanted to work on improving that. We implemented a few things when we got the list of client names each month from CARS. The supervisor or the lead RSC would mail the names to each RSC. We also created a monthly spreadsheet to track the surveys that were completed. I reviewed the survey names with staff during weekly supervision, and also a follow-up email was sent out to the RSCs to let them know which clients still need to be completed prior to the end of the month. We gave clients the choice of completing the survey either on their phones with a link or completing a paper copy, which then the RSC or the program coordinator would complete online for them and submit. Next slide.
We're
We're almost there.
Yeah, I know. It's buffering for some reason. I'm not quite sure why. So let's do our trick again. Let's do our little trick that we do. Let's see if that helps.
Okay, so where we are now, by July of 2021, based on our population, we were to complete 41 surveys within 6 months. And by the end of the 6th month, we had actually completed a total of 42. We learned that providing the reminders to the RSCs helped them remember to discuss with consumers, the survey with their consumers, and providing options to consumers made it easier for them to also complete the survey. So based on this outcome, we do plan on continuing to utilize these same tools in the future.
Well, we made it.
Thank you
It
for
was
your
a
help.
hard road, but we made it. Thank you, Barb.
Thank you.
Okay, so now we can move on to bricks and mortar, and that is the TCM providers. David, I'm assuming you can share your own screen, correct? Or do you need some help?
I plan on sharing.
All right, I'm going to get out of here then and let you do.
Just let me know when you guys can see it.
We can see.
Okay, cool. Like Amy said, this is brick and mortar, and Stefan and I did this with our TCM providers. This is Stefan Glover, the administrative coordinator for TCM, and I am the service manager. So the aim was to improve documentation for the consumer's electronic health record by giving technical support to our providers and improving the technical support they were receiving from us. Instead of giving an umbrella technical support, give it specifically based off of what the provider needed, specific to agency. The cycle we chose was January 2021 to May 2021. So the project was, how can we make the greatest impact on community service delivery? And the changes to see if the tier system helps to improve documentation. So the tier system, this was the plan that Stefan and I put together, and we brought it to our providers at several meetings. What is this going to look like? On tier 1, you would receive minimal monitoring when you submit information to Milwaukee County. Tier 2, you would receive more monitoring on the forms than tier 1. And tier 3, what all of the forms and some training. But it's one thing to make a plan, it's another thing to put it into action. So as we were carrying out the plan and we were looking at the SAR packages based on the tier level, we realized that tier 3 needed more technical assistance, which we were able to do trainings, special meetings, emails, and everything to whatever they needed, phone calls, to help them get the electronic health record looking a certain way. And we received a lot of feedback from all of the tier levels between the agencies. And we said, okay, let's put a survey together. How did you really feel about it? So this is the survey. We had 3 questions, and the first question, and I put the data based by question and the results based by tier. So we had 7 agencies with 3 different tiers. So the first question was, has the tier system helped your day-to-day job? 4 said yes and 3 said no. The ones who said no said that they hadn't changed anything that they're already doing before, and they're in tier 1. 2, in relations to the tier system, has BHD staff been responsive to your emails? They said yes. 3, what technical assistance did you receive since the tier system started? 3 said yes and 4 said no. When you notice right here, tier 1 did not receive any technical assistance, so the project was as designed. One of the things that we weren't prepared for when we moved from one set of tiers to another 6-month study, because from June to December, we changed the tiers based off of how everyone was doing. So when people moved up from tier 3 to tier 2 or 1, they started to reach out because they were used to the technical assistance that we gave in tier 3. And Stefan and I would hey, you guys graduated. This is wonderful. You don't need all of that support you received before. So as you know, with any project, you live to learn and adapt as we go. That's it.
Really nice job. Thank you so much. Okay, so we're going to move right along. And right now we have creating a breathing space during a pandemic from WCS. And do you need me to share my screen?
I think I should be able to share mine here.
Okay, let me know. Remember to turn off your camera if you're not presenting.
Is this looking good?
I don't see anything yet.
Oh, I didn't finish the process here. Let's see. There we go.
Yep, you got it.
All right. So my name is Alex Raharn. I'm with WCS with our community-based mental health programs. That's our TCM and CSP programs. And our project is creating breathing space during a pandemic, using halt prevention tools during a difficult time for recovery. So about what it is and why this is important. So just drawing on Stephen Malimas and the 5 rules of recovery here, kind of just looking at signs of poor self-care and how those affect, the potential for relapse, use, and decompensation for our participants. So we use the commonly adopted HALT acronym, which stands for hungry, angry, lonely, and tired, and use those to identify signs of poor self-care that may lead to relapse and use and decompensation for our participants. And we kind of viewed this through the lens of being something that's been exacerbated by the constraints of the pandemic. So kind of something we're just kind of looking to address with our participants during this time, not necessarily just related to substance use, but just kind of towards their mental health and just their general well-being. So the aim was to identify stressors that are related to these HALT indicators and to provide coping strategies to our participants via a simple information pamphlet and follow-up discussion about these things with their case manager and or treatment team. So the project details, I have some pictures here, but this is our little pamphlet actually here in person. So we created this pamphlet. Which was provided to the participants by their case manager, and the case manager would review these pamphlets and go over this stuff with the participants. The case managers for the TCM and CSP programs, along with the supervisors, clinical coordinators for those teams, were the change team for this project. And so we did a pre and post-test survey to try and assess each of these measures. And so one question was asked per HALT indicator, one for hungry, angry, lonely, and tired. So for 4 questions total. And we did this with 70 participants from our TCM and CSP programs. So the data collections, the survey, these are the survey questions that we used. Question for hungry regarding appetite, 1 to 5 scale rating there. 1 to 5 scale rating question for angry regarding mood swings, how much they're reporting those kind of things. For lonely, we asked a yes/no question regarding whether or not they report feeling isolated. And for tired, we asked how many hours of sleep they were getting per night. Our data collection here, pre-test was in February this year, post-test was in May, and the results were a little surprising to me. They actually showed a very slight decrease in the scores for the hunger question, as well as a very slight increase in the average scores for the anger question. So not necessarily the positive results we were looking for there. But as far as loneliness, there's a lot lower incidence of reporting feeling isolated. And we noticed that on average, clients actually were getting more hours of sleep per night. Just the visualization of that data, you can see the small increases and decreases there. So what was learned, I think most importantly for us, was that a significant portion of our participants surveyed reported struggles with one or more of these indicators that we attempted to measure. We found that the data doesn't necessarily show an overly positive effect from using this tool, but we think that it might come down to kind of just the methodology and the data collection, and maybe could have been maybe a little bit more concise on our questions for each of these issues. So maybe just simplifying the questions or the ratings or something like that. But in the end, we did find that this tool was actually a good opportunity for some of our participants to open up more and engage and have a conversation with their case manager regarding these issues. For example, we had a client who when discussing the loneliness was, you know, they reported to their case manager that they would reach out to their daughter that they had not talked to for quite some time to kind of alleviate that. And then there was also a client who reported a discussion with their case manager about regarding the tiredness and hours of sleep, how maybe that was like side effects of their medication, you know, and maybe that is something can be addressed, you know, maybe something that they weren't talking about before. So just kind of, it was good to kind of maybe get some of these conversations going. So, and yeah, since it's kind of unclear data-wise, you know, how effective this was, it maybe not something we'll be broadly implementing, but since it was a pretty simple program and it was very low cost and was, you know, of benefit to some participants some way, it's definitely something that we'll keep around kind of in our back pocket, you know, as part of the case manager's toolbox. And in order to do that, you know, we'll make sure that our supervisors and our clinical coordinators are aware of this resource and, you know, pass that along to new staff and case managers that come in. So that's all I got.
Thank you very much. Well done. And so make sure you unshare your screen. And if anybody, remember, if people have questions, to make sure to put them in the comments section so that we can save them until the end, just so that we don't lose those questions as we're going along the way. We are going to move on to golden ticket impact. Are you ready? Do you need some help sharing screen?
Yes, Amy, if you could share, please.
Oops. First things first, I got to share the screen.
Okay, good afternoon and welcome. My name is Pat Kateris. I am the Substance Use Disorder Program Director at Impact, and this is my 16th Marketplace storybook. I've been there as long as Janet. So, well, if we would be in person right now, you'd each be getting a little golden candy bar because I do stuff like that. So we decided to name it a golden ticket. This year was the first full year that the access points have gone to a fee for service model. Before we were a purchase of service. This year we became a fee for service. So that means we need to get our clients in so we can, you know, maintain our bills and maintain our staff and do that. So this was a whole new learning year for us. So ours is, yes, you have the golden ticket. I was the lead on the team. My team consisted of my access point screeners and my customer service representative. Our aim was to be proactive in increasing our community outreach for access point services. We felt this was important to make sure that we were getting assessments coming into Impact, but also to let people know that we were out there. We did not have to advertise before. We were sort of like known and people would bring it to us, but we really needed to get out there and let people know that we were available. Next. So our change was to reach out to the community when we had open screening appointments in Access Point. What we would do is we would have open times during the day that we could take assessments. So what I would do is I would reach out to the community. I have a few very key email addresses and I would send out an alert saying that we have slots open for today. If anybody on your caseload, if anybody that you know of, anybody that needs an assessment to get into treatment, to get their level of care, whether they have insurance or non-insurance, we have openings today. What has been with my staff, since we are doing a telephonic, that is an option for them. They've been able to do them later at night. So some of the probation officers and that have like that because their staff can still work. Their clients can still work and come after hours to do their assessment by telephone. Next one, Amy. The results of our research, we had a zero baseline because we never had to reach out into the community before. So we did this from January of 2021 till April of 2021. And the results of my reaching out to the community on a day when we would have slots available was a 63% increase for screening on that day. So more people would be able to send us emails. We have an email address that they could use to get their referrals in. Next screen, Amy. So we have decided to adopt this project. Thank you.
Thank you, Pat. That was wonderful. Okay, are we ready to move on to the next one? We have mediocre to magnificent, Lutheran Counseling and Family Services. Do you need help sharing your screen?
Can you see my screen?
So far, yes.
So you can see the presentation?
Not the presentation. What I see is the invite to the Teams meeting.
Okay, no. Okay, now you see it?
Yes. Oh,
okay.
No. Yes, no, yes, no, and yes.
Oh.
And yes.
Sorry.
No, you're great.
Actually, can you do it for me? I'm sorry.
Sure.
My mouse is being very touchy.
All right, let's see what I can find here for you. Okay, you all set whenever you're ready there.
Okay, I'm just trying to figure out how to get back to the screen. I can't see you.
Look on the bottom of your screen, you'll see that little Teams, the little Teams men, and you'll go into that.
Okay, thank you very much.
You bet.
Good afternoon. I'm Lisa from Lutheran Counseling and Family Services of Wisconsin. We provide outpatient mental health counseling, alcohol and other drug abuse counseling, in-school counseling, and adoption services. We have 11 therapists who are psychotherapists and also substance abuse counselors located in Wauwatosa. And we also recently added a new therapist, and therefore we have immediate openings. Our project title is Mediocre to Magnificent. Next screen, please. The problem was busy, outdated, and cluttered therapy office. This is our alcohol and drug abuse counseling room where we provide group and individual counseling. You can see it's the same room, different angles. Next screen, please. The goal was to make clients feel more comfortable and welcomed, and to provide an atmosphere for them to feel calm, encouraged, positive, and inspired. So we surveyed 23 clients about the room before and after. We asked several questions. The first one was, have you observed a difference in this room? 20 people said yes out of the 23. Second question, did the setup of the group room help you feel more comfortable to share your thoughts and feelings? And 19 people said yes. Third question, has the feel of the room impacted you? Out of the 23, 15 said yes. The next question, does a room make you feel calmer than it did before? 13 said yes. And the last question, do you feel additional changes need to be made to the room? Some people said no and some said unsure. Next screen, please. Client testimonials. One of the clients said the room feels feng shui. Another client said the office felt depressing before, which was interesting. And now the atmosphere made them feel good. The therapist, the AODA counselor whose room it was, said that she didn't think the office could feel could look that good. And she said it made her want to cry, and she actually did cry because she was so happy how it turned out. Next screen, please. And here's the final results, different angles of the room. The fourth angle I couldn't fit on, and that was a full-size 12-step poster. So that's all I have, and thank you for your time.
Thank you very much. That was very nice. The room did turn out very good.
Thank you.
Okay, so then we'll move on. Let's see. We are on number 8. And we are on staying connected. And it's Project Access.
Hello.
Hello. Do you need help sharing your screen?
I think I got it. Hopefully.
Okay, then I'm gonna just leave it as it is right now, and then let me know if you get stuck. Okay.
Okay. So my name's Carrie Wiscochill. I'm an intake coordinator with Project Access, the CCS program. We also have Sarah Wabshaw, who's a care coordinator with the CSP program that is, I believe, on the phone. But let me share our screen, hopefully, maybe. Oh boy. Let's see. Share. Is it working?
Not yet, just still see the black screen. There you go. You got it.
Okay. All right, good. Oh, and I keep losing my notes. So Sarah and I did a project called Staying Connected. Basically, our concern was we had no protocol for clients when they disengaged from our services. So we were having an increase in clients going MIA and disenrolling from our programs because we weren't able to locate them. And kind of everybody was doing their own thing on, how to try to get them re-engaged. So we wanted to put something together to make sure everybody was doing things cohesively, and that we were taking all the necessary actions to locate the client, to get them re-engaged, and hopefully stay connected with us with our services. Sorry, I'm looking at 2 different screens trying to look at my notes as well as the screen. So we kind of collected data from January 2021 to March 2021. And we actually found out that 25% of our clients between CCS and CSP were being discharged due to MIA reasons, whereas 75% were being discharged for other reasons, such as being incarcerated, or they were choosing to disenroll, they transferred to a different program, or client death. When we pulled all the data, we actually found that our percentages were way less than we thought they were going to be for clients going MIA, but we did decide to still continue on with the project to hopefully get it down to 10% was our goal. To reduce our discharges down to 10%. We found that there was a lot of confusion with how each person was handling a client when they disengaged. Some were doing it one way, some were doing it another way. Then when it came time to staff the clients for discharge, we would get a lot of feedback from, Milwaukee County, asking us to call the medical examiner's office or try their emergency contacts, where some people were doing that, some weren't. So we wanted to put something together that captured everything, and so that it was all, again, cohesive. Sorry, I'm kind of rambling. So we developed a protocol. What we did was we kind of asked for staff feedback on what they were doing when a client disengaged. And we collected all of their data and put it all together in what we call a protocol. So this consisted of, and my next slide will show like what the protocol looked like. But like mailing a client, like, hey, reach you, please contact us within a certain amount of time. Contacting hospitals, calling support, making unannounced visits, calling the medical examiner's office, and things like that. With CSP, they have some more high, CCS does too, but more so in CSP, some more high-risk clients where they're being seen multiple times a week. So we did develop a little bit of a different protocol for them. So once we put it all together, this is kind of what it looked like. We thought it was the feedback we got from the staff was it was really helpful actually when it did come time to staff them for discharge, because they had everything lined up right there with the dates that they did everything. So they didn't have to go back through like progress notes and try to find, you know, hey, when did I call so-and-so or whatever the case may be. This for our 30-day protocol started at week 5. You know, since there's 4 weeks in a month. So we started at week 5 and we go all the way through, you know, the 90 days no contact. And then for our high risk protocol, again, it was a little bit different. We did, get to my right now. Again, this was more for our CSP clients. We wanted to really capture, hey, you know, they're being seen more than once a week. So after that first misappointment, we're doing a follow-up phone call. The second misappointment, we're again calling them, contacting, you know, landlords, providers that they're working with, any of their emergency contacts. And then at that third miss visit, thinking that it would be within that first week that we're doing drop-in visits, requesting wellness checks, things like that. If the no contact continued, then we would kind of move on to the 30-day no contact after this was followed through. So we thought, hopefully, that with the protocol that we put in place, we would have more clients becoming, you know, being relocated. So we wanted to try to capture what we can do to keep them engaged, to keep them from dropping off again. Some of those things consisted of, you know, asking the client, you know, the reason and why they missed the appointments. Maybe there was some barriers that they were facing that we weren't aware of. Possibly looking at maybe changing the schedule with them. Just really looking at their overall lives to try to make it easier for them to stay engaged with us. And then obviously, coming up, you know, last case was coming up with a scheduled team meeting to discuss keeping them re-engaged. So then, again, our goal was to get it down to 10%. So we collected data from April to August, and for the most part, we met our goal. We were at 10.6% went MIA, and or 10.6% of our discharges were due to clients going MIA, and 89% were for those other reasons. Overall, with CCS, the staff that we spoke to that started the protocol, it reported that it was about 75% successful with getting them re-engaged. They started the protocol, they were able to relocate them, get them re-engaged into the program. With CSP, we have 4 different CSP teams. Unfortunately, we were only able to collect data from one of the teams, and they reported back with 50% of the time it was a successful. So overall, we felt that our protocol was working. Worst case, if they were going to be discharged, it was definitely helping the staff with making sure they've dotted all the I's, crossed all the T's, making sure that we haven't forgotten anything. And that way, when we were ready to staff it, we were good to go. And I think that is it.
Thank you so much, Project Access. Okay, so be sure to unshare your screen. And we'll move on right along to the next person. I just want you all to know too that we're moving on to number 9. And I know this is a little nerve-wracking and you're all just doing so wonderful. So I just wanted to just plug that in here right now, because I know that public speaking isn't everybody's favorite thing, but you really are doing wonderful. So we're going to move on to Jerome. And Jerome, do you need help, La Casa, sharing your screen?
I'm going to actually give it a shot here, I think.
Okay, give it a shot. Let me know. Oh, yeah, I can see it.
So we're good to go?
Yeah.
I'm Jerome. I am the TCM CCM supervisor at La Causa. Our project was a change in scenery work in progress. The building on the left was our CEC building. We initially worked out of that office, and then due to the pandemic and other reasons, we ended up sliding over to the other social service building that La Causa has, juveniles or youth social services, and we joined over there. Some of the issues that we had is we really loved the Community Enrichment Center. We called it the house. It was a building that was in the middle of the community. We were able to meet individuals on a regular basis. We were in a close-knit setting for the case managers, and moving over to this building, and I included sort of a picture of the generic desk for what it looked like. The morale wasn't very well. Again, we're in the middle of the pandemic. We didn't want to move. We're not seeing our consumers. We just struggled with everything. So we ended up doing a survey to find out what would motivate people more, what could be some of the changes that they were asked. And as part of that survey, it was sort of, you know, are you satisfied with your current setting? How would you like to improve? Some of the things we asked was make it more personal. Could you be more green with flowers, more privacy, or other things? We brought some of that to management. Some of it we were okay to do, and we ended up moving and becoming more personal. And I included a couple of the desks that were there that looked nicer than what mine does. And that's where we came up with pictures and flowers and little sayings and you know, sports memorabilia people were able to put at their desk. We have other things that we've asked that management is still looking at to improve our self-care and improve where we're at. And I think the outcomes as we came through from sort of having the low morale is the TCM, CCM team, it placed and maintained a Tier 1 status through BHD. I know David had talked about that before, but you know, we had some struggles initially, and moving in here, we were motivated. We've been able to retain most of our pre-COVID staff. We did have some people that left, but we've added some people to the team. We've maintained continuity amongst the team. The CCM surveys, we've met the required number with a higher rate, average approval rating. We've had, because of that, we have a higher fee for service reimbursement that's been given to us that we've been able to utilize for the case managers and the peer support. The other interesting one is we did have an original NIATEX project that we were going to do that was more consumer driven, and that was based on asking the consumers, how would you like us to improve the services that we were providing during COVID? And we had this great survey. We ran through the survey. After talking with Michelle, it was like, hey, we did such a good job with that, we couldn't even use that as a project because the consumers were happy with the level of services that we were providing. Lastly, we did TCM surveys through BHD. We've met the required amounts for that. We hit the higher than average approval ratings for the consumers. Some of the data I've actually included from the dashboard that we get through BHD, the number of surveys that we completed, the rating that we needed to attain. At the bottom is myself as part of the team. Micheline Riley's in the middle. She's a certified peer specialist and has been with La Causa, I would have to say 8 or 9 or 10 years. And Bruce Words is the lead and was also on this team. He's been with La Causa for quite a long time. I think the last thing that we're really trying to work on now is to get the building more open so that our peers are going to be able to start to do some of the activities that they were doing before at the CEC. We had a big open spot. Peers were able to work on crafts and do games and watch movies and a bunch of other things. So that's still our last work in progress that we're trying to do, is to make this more of a welcoming spot for our consumers and especially for our peers who work very well with the consumers in doing things to help them maintain their mental health and the other things. And that's all I have.
Thank you very much. Okay, just be sure to unshare your screen and we'll move right along. Good job.
How do I unshare?
So that little box at the top, it's a white box and it's got an arrow or an X, and it probably has an X in it right now. And so you're going to want to, yep, push that and it will turn into an arrow.
I had an arrow all along. I had everything figured out but that.
So just on the very, very top of your screen, there should be a little white camera and a little.
I see stop presenting maybe?
Yep, try that and see if that works. There, you got it. Good job. See? Great job. Okay, so now we are moving on to perfect match. Audrey, are you ready?
Yes, I am.
Okay,
pull it up.
You're going to pull it up? Okay, let me know if you need help, okay?
Mm-hmm. It's under more actions, right? Oh, nope, never mind. Arrow. Sorry.
Take your time. And just let me know if you need help.
Okay.
I see something happening. There, you got it.
Beautiful.
You got it.
Alrighty. My name is Audrey List. I'm with Broadstep Behavioral Health CSP program. I'm a case manager there. I just wanted to say ahead of time, the tools that we used during this process are all linked at the end of my PowerPoint. So Perfect Match was our project to help people in our program get connected to housing. Yeah. Okay. So we had kind of two aims. The first was to increase our team's knowledge of housing resources in Milwaukee County. There was a significant, when I started in the program in January, I noticed a significant lack of knowledge and wanted to do something to increase that. So we wanted to increase staff knowledge in order to also increase housing satisfaction and find our CSP individuals their perfect match. So we started thinking about stuff in March. We created the concept of doing a pre-post survey as well as the training. So I developed the pre-survey in about April, May, and then in June, I handed out the pre-survey and created the PowerPoint training that I did in July. And once that training was over, I had also trained them on our new housing tool that they then utilized in August. In September, we then did a post survey, both on their housing knowledge and how they utilized the new housing tool and how that worked for them, to kind of gauge if it was working.
And then, I don't know if that's in the way. Let me minimize that. And then in October, we realized that we needed to do, based on our post-survey data, that we needed to do more trainings because housing, as everybody on this meeting knows, is a very complex subject. And training specifically on different types of housing resources, you know, county versus city versus federal, and what all those programs were, and a bunch of other trainings, as well as the need to use the housing tool with our individuals rather than on their behalf. We had a lot of people who used them on their behalf, and the data was not quite as accurate. So again, what we learned, complicated. So we had talked about doing the housing trainings at least on a quarterly basis in order to get the most staff access to the information. We actually did our first training of the new trainings at the beginning of this month, I believe, on how to do a showing with individuals and how to prepare them for that, rather than either doing it on their behalf or just, you know, winging it. So there's a large list of trainings that we're looking at utilizing going forward. So as you can see, we adapted using the housing tool. In addition to those quarterly trainings and additional trainings as we had availability for, I also created a housing corner in our office that has listings and community resources for things like clothing, eviction prevention. We started like a little clothing closet back there. And so we really started to implement this idea that housing and having the conversation with our consumers about housing was very important so that they could find their perfect match. So these are the links, and that is all I have.
Great job. Thank you so much for sharing. Okay, and yep, I just was going to ask you to unshare your screen, and you already did that. So thank you so much.
Thanks.
Wonderful. Okay, so we'll move right along, and we'll move to CCS. And Tamara, you'll have to, I just want to make sure I'm saying your project correctly. Is it the C4 project? Is that correct?
Yes, it's a C4 project.
I did it good. Okay.
And I've got it, so I'll go ahead.
Great.
Okay, can you see my screen?
Not yet. It's coming though. There it comes.
Okay, good afternoon, everybody. My name is Tamara Lane, and I oversee the CCS Ancillary Network, which is all of the services outside of care coordination, and I work for CARS. So for this project, we wanted to tackle this notion of collaboration. CCS, for those of you that don't know, one of the primary principles in the program is this idea of a multidisciplinary team working together to collaborate and support someone in their recovery. Now, the trick with CCS is that typically the recovery team is made up of a lot of different providers from different organizations. So collaboration can be a huge challenge in the CCS network, hence why I selected the mountain to kick off the project. So the C4 project, the full name, collaboration, coordination, cooperation, and calendars. So our project target was to increase ongoing collaboration between our care coordination and ancillary providers within the CCS program. And basically, as the course of the project progressed, we really decided to focus in on 6-month recovery team meetings. In CCS, at least once every 6 months, consumers are required to have a recovery team meeting of all the different providers that they're working with. So the care coordinator really helps facilitate that process. And we wanted to just hone in on ancillary attendance at those recovery team meetings, which we decided to measure through billing. So when ancillary providers participate in 6-month recovery team meetings, they bill a very specific code for their participation, and that's our H2017 SPANC code. So that code is reserved for participation in those team meetings only. So what we did to measure the progress with billing is we took a baseline, and that baseline measured billing, SPANC billing from October of 2020 to the end of January 2021. We started our project on March 15th of 2021, and then we did our first progress report. The time period we looked at was April 2021, the beginning of April 2021 to the end of June 2021. And then our final report, we looked at the time frame of billing for July 2021 to the end of September 2021. And our target outcome was to increase SPANC billing by 25% by the end of the project. So our interventions, the first thing we wanted to do is we wanted to make sure that ancillary providers were billing properly, because if you're going to use billing to measure your progress, you need to make sure that your billing is accurate. So there's 2 codes that we honed in on. One is FANC, which is really just the ongoing collaboration between the care coordination teams and ancillary providers. There's a few other things that get factored into that as well, but that's the primary reason for the code. And then this SPANC billing. So we created a tool to really outline what needs to be billed under those codes, what case notes should look like, and we distributed that to all of our ancillary providers just to reinforce solid billing practices. Now, our care coordination teams, for each CCS consumer, they created email groups to support this scheduling of the 6-month recovery team meetings. So their job was to work on sending recovery team meeting invites out at least 4 to 6 weeks prior to schedule RTMs, to allow for ancillary providers to actually schedule and plan so that they could attend the meetings. In addition to that, the CARS team worked with our care coordination supervisors to develop agendas for those meetings, an agenda template to help our care coordinators facilitate those meetings more effectively. So the agendas were to be attached to these meeting invites that are sent out 4 to 6 weeks in advance. So here are the results. When we did our first progress check, measuring the billing from April of 2021 until the end of June 2021, we saw a slight improvement in SPANC billing, very slight, like 1%. Anecdotally, what we heard from the teams when we checked in is that ancillary providers were attending more meetings. They were finding the interventions to be impacting CCS in a positive way, and they wanted to continue with the project. Now, when we took a measurement from July to the end of September 2021, we actually saw an overall decrease. So statistically, this project wasn't successful, but the project itself actually was really successful because it gave us a few things. So what we landed on after talking about the project results as a group last week is that basing progress measurement on billing is not a perfect methodology. That really providers have a tendency to wait that 60-day time period to get their documentation and billing into the system, which isn't really best practice, but it's what policy dictates. So we really want to take a look at other ways that we could measure ancillary provider attendance, because what we heard during the discussion we had last week is that ancillary providers are definitely attending. And what recovery with the care coordinators are actually seeing is that ancillary providers are not billing that participation appropriately. They're there and maybe not writing a case note. So there's definitely some things that we can take a look at to really help us improve this collaboration and how we measure it moving forward. In addition, the methodology that we used was good in some fashion because it gave us the ability to watch trends by agency to see who is making some improvements in billing and who isn't, so that down the road, when we're developing our contract performance measures, we could potentially make this a performance measure and use a similar methodology to measure the progress with those different targets. And it just opens up a really dynamic conversation with the team so that we can figure out like what is still the issue here? Why are we not successful with talking to each other? And we had a great conversation last week, and even though this project wasn't a success, it really is going to lend to a more positive future state as far as collaboration goes. Thank you.
Thank you, Tamara. Oh, I've got an echo. And I'm not quite sure why. Okay, so, and thank you for unsharing your screen. And I believe that the next project is actually like a continuation of this project, right?
It is.
Yes. Okay, and so your project, I forget, is it C42?
It's C4 from a care coordinator's perspective.
Okay, got it. And then do you need help sharing screen?
I got it.
Okay.
Hopefully. Can you see my screen?
Yep, you're all set.
Okay, so perfect. So my name is Megan and I work at Outreach Community Health Center. I am one of our care coordinators and I am also one of our intake coordinators. So our project kind of piggybacked off of counties, and it was how our CCs were implementing their project. So our goal was to increase our contact with our ancillary teams to at least one contact per month per provider, and also wanting to increase their participation at our recovery team meetings. Our goal was to provide 30 to 60 day notice for team meetings, allowing everybody to make room in their time. Some barriers that we faced were buy-in by the CCS team. It was one more thing to remember to do, one more checklist to send. So that was difficult in the beginning. And also the participation of the ancillary providers. We were kind of subject to them answering our phone calls or our emails and showing up to our team meetings. Also, our cooperation of our clients, some went missing, some wouldn't schedule that far in advance with us, canceled short notice. So we were doing last minute RTMs to try and get them in their time frame of their 6-month and annual reviews. And also our baseline was 0. No one in our agency and or other CC agencies were kind of tracking whether or not we were really communicating with the rest of our team. So where to begin? We came up with a tracking sheet in about March and implemented it in April of who the providers were on each team, what their emails were, phone numbers for them, and also setting reminders for ourselves to invite them to RTMs 30 to 60 days in advance, often using Microsoft Teams for COVID purposes and social distancing. And what we found was that when providers had more notice, they were more likely to show up, which was helpful. In those emails that we also sent with invitations, we were asking for things such as strengths, barriers, goals they were working on, how their work scores or the Wisconsin Recovery Team scores were playing an effect in the treatment they were getting and if it was increasing those scores. And we found that our CCs were reaching about 78% of our providers each month. So our contacts, in blue here are the number of clients that we had reported, the number of providers, and the number of contacts that we had. So we were able to reach about 78% of our providers each month. And here we tracked the invitation for team meetings, whether invitations were sent 30 to 60 days in advance, and then that less than 30 days. So the green would signify if we were getting information before the RTMs, which was what we were requesting. So those strengths, barriers, and goals being worked on. The yellow is whether or not they showed. Red is if there were some providers who were not sent invitations to meetings for whatever reasons. Sometimes clients didn't want certain providers at the meetings, and blue would be the invitation sent. So what we found is with more time, they were able to get us information in advance to best complete their RPOCs or their recovery plans for the next 6 months and show up and participate in those meetings. So what's next for us? We are going to continue to invite those providers in as much advance notice as we can. That 30 to 60 days will still be our goal. And also that continuing monthly contact. What we have found is that we're best able to contact everybody through email, and that's how we're getting the most responses back as well. Some questions that popped up while we were doing this project is if it was our additional contact with ancillary providers increase our clients' WORD scores. So if having a more involved team or a more passive team, which would influence those scores and help them reach their goals quicker. And the other question that kind of developed from this was, how does this increase our clients' accountability? Will they show up for one provider but not another? Why? What's the barrier there? How can we help address those barriers, and how can we work as a team to best support our clients? So those will be two other questions that we'll kind of be looking at as we continue reaching out to our ancillary providers once a month.
Wonderful. Thank you. Okay, so it looks like you've already unshared your screen, and so we'll go ahead and move on to the next project, which is Whole Health Clinical Group Pan No Show Project. Did I say that correctly?
I'm not sure. Yeah. Yeah, you did.
Do you need help sharing your screen?
We'll find out.
Okay. You got it.
How about that? All right, so as you stated, this is the Pinot Show project, which is short for Psychiatry Appointment No-Show Reduction Project. Let's see if I can, and Nicole's joining me here. She is also from Whole Health Clinical Group and helped put this thing together. So we noticed late last year that we were having difficulties getting enough appointments in for our psychiatry program. So we have an outpatient clinic. We have a number of psychiatric providers. We have several case management programs, CSP, CCS, TCM, that all utilize our psychiatric providers. And there's some growing concerns with our clinic that we are not achieving satisfactory levels for our psychiatric appointments. So we did an internal assessment, and it was completed, and we confirmed that we need to address this particular issue as it impacts all of our programs. It's impacting our continuity of care with our clients and between programs, so it's something that we needed to address. We learned that our communication between providers and programs was not effective. Specifically, our interdepartment communication needed to improve, and some of the incoming calls were also getting lost. So there were some things that we needed to work on. So our aim was to decrease the overall no-shows and cancellations. So we have some data here from 2020. We decided that it was time to huddle up. We implemented something called the huddle. which is just a gathering of our supervisors and our staff on a daily basis to make sure that we are connected to our psychiatric appointments for all of our programs and our providers. Upon the revelation of our lacking communication to ensure client attendance to our psychiatric provider appointments, we implemented the huddle in September of 2020. Daily brief, including the program manager, supervisors to ensure ongoing outreach efforts being completed to ensure client and psychiatric provider connectedness. So if you take a look at the data from last year in 2020, we implemented the huddle in September, and you can see the NS rate and NSCA rate at the bottom there is the cancellation and no-show rate. So we had pretty consistent rates in the 20s and even 33% in March. And then after we implemented the huddle, we got down to 18, 19, 18%. If you look at the quarterly numbers at the bottom, a combination no-show and cancellation rate 27% and then down under 20% by the end of the year. I also pointed out before how some of our calls were getting lost too, and we figured that was also contributing to our poor psychiatric appointment attendance. So we also included adding a phone tree in January of 2021. So we changed how our calls were coming in. So to address the ongoing confusion with clients and external providers calling to set up appointments, we implemented a new phone tree. If you look at the previous slide here really quick, remember that we were at 27 in the first quarter, and then great improvements here towards the end. Even better improvements here in our early 2021 numbers. Our overall no-show rate in the first quarter was at 11%, and the next quarter at 15%. So in June of 2021, our clinic moved. So we had our centralized clinic operations at a different location. We moved into our building that we're currently at 20th and Wells. And that enabled us to also change how we did things in terms of incorporating our psychiatric appointment scheduling. Allowed us to realign our reception and implement psychiatric appointment scheduling that includes direct scheduling with case management, eliminating any opportunity with confusion, too much involvement with reception. And we kind of had too many cooks in the kitchen. We identified that and we were able to change that too in June. So note the combined no-show rate compared to 2020, like I said, so we had some improvements. We're pleased with the results, but we're not satisfied. To ensure ongoing implementation of our interventions, we believe that we're lacking a little bit of oversight in our process. So we've since hired a clinic director who will be involved in this project moving forward to assist ensuring our no-show rates remain low. We'll also work together to continue to identify any further issues that could improve our overall satisfaction with our clients and staff. That's all I got.
Great job. Thank you so much for sharing. Okay, and remember, if you do have questions, to go ahead and plunk them in the comments section. I know that there have been questions that have been asked. If the presenters would like to answer them in the comment section, that's awesome. If you want to wait till the end, it looks like we probably will not have time at the end. We are a little less than halfway through, and we only have 45 minutes left in this meeting. So I just wanted to state this, that I know that this meeting usually only runs till 3:30. So what I'll do right around 3:30 is I'll go ahead and plunk the certificate of attendance in the meeting for those that can't stay, and for those that can join us till the very end of all the projects, then please be encouraged to do so. Okay, so I'm going to move on, and it looks like we have our space next. Walking with, not above. Do you need help showing or sharing your project?
Yes, please.
Let's see what I can muster up here. Walking with, let's go to the end. There you are. Let's see. Let's see if it will let me. Can you all see that?
Yep.
Oh, it will let me advance. So let's just go with it. Hey.
Sure.
Okay.
Thank you. So I'm Maddie, and I'm with Our Space, located in Milwaukee, and we are presenting Walking with, Not Above. So this title comes from a direct quote from one of our certified peer specialists who shared, "As peer sports, we are here to walk with them, not above them in their recovery journey." And this is going to be more of an educational plan, more than a case study itself. So we can do the next slide, please. You could do the next slide, please.
It's doing the thing that it does. So let's see if it will let us. Sometimes with these, they do not want to cooperate. So let me come out and come back in. Sometimes that does the trick. So let's give it a go and see if it will help us. How's that?
Perfect. Yep. So a quick description of our space before we dive into the main topic of peer support. At our space, our mission is to empower individuals living with mental health and substance abuse issues to achieve their full potential by providing recovery-oriented, person-centered services and programs in a safe and accepting environment. We are a small community that cares and grows together day by day, and one service that focuses on this is our peer support services. So what peer support services are, they're delivered by individuals who have common life experiences with the people they are serving. And because people with mental health and or substance abuse disorders have a unique capacity to help each other based on a shared affiliation and a deep understanding of this experience. In self-help and mutual support, certified peer specialists offer encouragement, strength, and hope to their peers, which allows for personal growth, wellness promotion, and recovery. And in more colloquial terms, it's a friend-like approach to helping someone in their recovery journey rather than a clinical one. And it starts with an individual wanting to start their mental health or substance abuse recovery journey and turning to a community-based service like WCS, for example, who would then refer them to our space peer support services. Then if approved, they are assigned a certified peer support specialist and begin meeting or talking with them often about their recovery. An example of something peer supports do with their clients is go for drives around the city, talking about their issues they're facing, long phone calls, or meeting at their apartments and teaching them coping skills to deal with stressors or other triggers. It's a very hands-on approach that has unique benefits. And so why we chose peer support services to highlight over our other services is because we think it would be valuable for the mental health world to know more about the benefits in recovery. And the next slide, please.
Doing the thing again. So we'll do we will accommodate it. We don't like it.
3 of me now.
Okay. So there we go.
Awesome. So which brings us to our change project. So our aim would be to bring more attention to and investment into peer support services in mental health field. Our audience is the behavioral health departments and services throughout Wisconsin to educate them on peer support benefits in the field. Our change team would include our space and our certified peer support specialists. And in terms of data collection, we used existing data from scholarly articles, as well as our space members' testimonials who utilize peer supports. Next slide, if it's working.
Well, I'm going to try something special.
Oh,
how about
yay. Good hack. So starting with the existing data, peer support has been found in the mental health field to reduce hospital administration rates and longer community tenure, decrease substance use and depression, increase sense of control and ability to bring about changes in their lives, increase sense of hope and inspiration, increased sense that treatment is responsive and inclusive of needs, increased empathy and acceptance, camaraderie, and increased self-esteem and confidence. And all of these sources are on the very last slide where I have kind of our works cited. But yes, next slide, please. So then I asked some of our space members who utilize their peer supports, and we asked Zach, whose peer support is Robbie, and Alicia, whose peer support is Jen. So they shared that peer support teaches me how to be independent and feel like a man. It's teaching me how to handle day-to-day life. I enjoy working with peer support because it's helping me in my recovery and becoming a better person, Zach shared. Peer support has taught me healthy coping skills to manage my mental illness symptoms like deep breathing and relaxation meditations. And peer support has helped me because it feels like talking with a friend with really good resources, shared Alicia. So what are we going to do with this information? Next slide. Our plan is to inspire, educate, and market. So the Health Education of England has identified developing and supporting peer workers as an important part of the future of mental health workforce strategy in an area where more attention and investment is needed. Educating people in the behavioral health field on the benefits of peer support services and inspire more investment in the peer support services and mental health, and bringing awareness to the benefits and success stories of peer supports in mental health will inspire those to learn about more to learn more about peer support services and possibly utilize it themselves. Emphasizing these will help us reach our aim of bringing more attention to and investment into peer support services in the mental health field. And thank you. So the next slide just is a thank you. And if you guys have any general questions, there's our case emails, and we're excited. Thank you.
I'm coming back to you. Hello.
Hi.
Let me come back and unshare my screen. Okay, good job. Well done. Okay, so now we are going to move on to the next one. We just got done with our space. And I know IPS cannot stay past 3:30. Would anybody mind if we moved up Beth to the E3, engage, empower, and employ? Would that be okay with everybody? Beth, are you ready?
Yeah, I could go if you'd like me to.
I'm
Thank
gonna
you.
sneak you
Appreciate
in
that.
now if that's okay.
Sure. Thanks, Amy. Appreciate it. Hello, everybody. So I am Beth. I work for CAR, specifically focusing on the IPS program. And so this is the first NITEC projects that I have done. And it was, again, revolved around everything employment. So our change team consisted of the IPS supervisors, both on the adult side and on the youth side. So they were the ones that kind of assisted and helped through this project. So our aim, one of the things that our goal and one of the things we actually look at on a regular basis is the increase of engagement of IPS services by youth and adults. And so we wanted to see if we could get more people basically involved in IPS services. So why did we want to do this? We know that employment is a prevention intervention, so it focuses on a full life. General data shows there's a cost savings when people are actually employed. It also offers purpose, identity, and all those great things that really we look for in people's recovery. So really wanted to get more people involved into the program. So what did we do? So we kind of started by talking with each other, talking with care coordinators, trying to figure out how could we get more people interested? How could we share the information a little bit more? We had done a few things related to flyers, things like that. And what we came to is that we wanted to try to create a video. So something that people could look at, that it was in the moment. That was one of the things that we heard from people, is that oftentimes IPS might be coming in maybe a couple of days later and the person might not be interested. So really wanting something to be very in the moment, that as a person expressed interest in employment, they could pull something up and be able to show it. So we created about a 3-minute kind of PowerPoint hitting on some of those key things that people were interested in knowing about IPS, so that at any time someone could pull it up. They could show it to somebody, or if a care coordinator wanted to know more about it, or a peer support specialist, or whoever that might be, could pull it up and be able to look at that. We recorded it. We originally put it into a Google Doc and then later put it into a YouTube video, which I will put in the chat if anyone wants to look at it at some time. And then we started to share it out. So we shared it out through all of the employment specialists across all of the 5 teams that we have here in Milwaukee. We did a couple changes when we were starting to share it out. So we realized that maybe we weren't hitting everybody. So we did start to share it, ask that it be shared at recovery team meetings, ask that it be shared at intakes, and then also, again, continuing to talk about it monthly as a team and trying to figure out more ways that we could make sure that we were getting the information out. So we looked at this. Our baseline was basically, we started the first quarter as kind of our baseline data. It was a little bit hard for me to kind of determine because we kept adding on teams. So looking at the percent of referrals to IPS kind of ebbed and flowed because of adding new teams. But this was data that we were already collecting. And so we are really looking at that June 1st through end of September is where we were looking for that increase. So that was kind of the end of quarter 2 into quarter 3. We saw a big dip from June to July of referrals, but then again, we saw them start to slowly go up. And I think that's really when we kind of ramp up really sharing more information. So overall, there was really only about a 1% increase in referrals. I think we were hoping for more. It didn't really happen, but I think we were still happy to see the increase. We got a lot of verbal feedback from care coordinators and people that they really did like to be able to see this and have this as an item. So it is definitely something that we're going to keep. But what we kind of, again, did learn that having that thing where somebody can share right on the spot is very helpful. Being able to visually see things was helpful for the people that were being able to see it, the people that gave feedback on it. It was really more of the method of sharing out kind of got a little bit confusing for, I think, for people, again, because we changed the method. So again, we'll have to confirm that a little bit. And we also realized that we maybe needed to share different information in the video. So kind of, we are going to continue to modify the video and start to be able to share it earlier on. So share it when we train out on IPS 101 and things like that. So something we will continue, but obviously going to do some modifications as we go along. So thank you. And thank you, Amy, for letting me go early. Appreciate it.
Yep, I knew we'd be able to sneak you in there. So, okay, well, thank you so much. Well done, Beth. And I think we'll move on to the next one. And it looks like we have satisfaction guaranteed. Serona Recovery, are you ready? I see a face.
Hello. Now I'm unmuted. Sure, I'm ready.
Hello. Okay, do you need help sharing screen?
I don't think so. I'll give it a shot, and if it doesn't work, then we'll get some help.
All right, take your time. Let me know. You're all set. I see it. Yep, I see it.
Everyone can see it?
Yep, you're all set.
All right, so I'll start by saying I don't actually work on Access Point. I'm covering. Megan was not able to be here, but I'll do my best. So for Satisfaction Guaranteed, which is the name of our Access Point project, the goal was to meet or exceed collecting or having a 90% rate of giving satisfaction surveys to the people that complete CARS assessments. And the hope was that this would help us, I mean, one, obviously get an accurate measure of what clients thought of the experience of doing the screens with us, and then start to, develop a kind of list of things that we can do to improve or make the program work better for folks. And the targeted population was all the folks that are referred to us for assessments. For the 2 cycles, what we did was, or what Megan did really, was put together or add to the checklist that the screeners already used to include completing the screen, and then including that also in the data points that they send to Megan after completing any of their assessments. And the results were relatively good. We ended up, we didn't hit 90%, but we were able to get the surveys to 84% of the people that completed assessments. And you can see broken down here kind of why we weren't able to get a hold of some of those people. 13 of them were in custody, and we couldn't really figure out a reliable way to give them the survey without having staff influencing how the results were recorded. 4 clients just declined to participate, and then in 3 instances, the AP intake specialist forgot to give them a survey. So moving forward, I think we still want to hit 90%. We think is a reasonable number to hit, and then we will start adopting the acknowledgement of sending the surveys as part of the checklist for the people doing the assessments. And we'll keep building a list of the things that we know we can change and start using the information from these surveys to improve the Access Point program. And that's what I have on Access Point.
Well, thank you. Even though you didn't think that you'd be speaking today, you did great.
Thank you.
Okay.
Now, if I can, oh, there we go. Stop presenting.
Yep, you did good. Okay, so if it's okay, then we'll move right along. And it is Professional Service Group, Shining Light on Special Populations. Do you need help?
Yes, my computer just turned off, so now I'm on my phone.
Those darn computers. They just do whatever they want to do.
I was like, are you kidding? Like, it works fine the entire time, and then, 5 minutes before I present is when.
Okay, let's get you up and running here. Can everybody see that?
Yes.
Okie dokie, you're all set.
So my name is Tessa Reynolds. I'm a care coordinator at PSG in CCS. We did shining light on special populations, which was essentially, we picked 3 groups of people that we might see come into our program that we may not know a whole lot about, and pretty much did more research. Go to the next slide, please. So the goal of what we were doing was to, provide care coordinators with resources and knowledge for special population in order to improve quality of services for consumers. We know that every single consumer that we work with is completely different, but there are subgroups that I think maybe we don't know a whole lot about. So we specifically chose single parents, like what resources are out there for them, folks with severe substance use disorder, and the LGBTQ community. The 3 groups that we chose for our summer series is what we called it. Next slide, please. So we wanted to increase care coordinator knowledge so they feel more confident providing care to consumers. So we split up into, there were 2 people, so 6 total, and 2 care coordinators would pick I don't know what I'm trying to say. All 6 would pick a topic that they wanted to learn more about, and they researched it and then presented it to us in a team meeting. So June, July, August, every team meeting we presented on a special topic. Next slide, please. Not surprisingly, here are results. So for parenting and substance use disorder, there were a few people who felt pretty comfortable working with this population in the knowledge that they had, but no one felt like they had sufficient knowledge to work with people in the LGBTQ community. And afterwards, we all felt really strongly that we had a lot more information to be able to support them. Next slide, please. So it shows that care coordinators reported feeling more confident, as you can see. Next slide, please. So we want to continue monthly trainings to provide knowledge and resources for special populations and other requested topics. And what was cool, an additional thing that we learned while doing our little summer series is that some of our care coordinators do have a lot of knowledge. Like one of our care coordinators did her internship at the LGBTQ Community Center in Milwaukee and had a lot more knowledge than someone else. So she was able to share that. And maybe just it opened the door for more conversations that we might not have been able to have. So we want to continue doing that. And thank you so much. I think that's it.
All right, thank you so much. I'm going to try to come back to you guys right now. Always takes me just a moment. All right. Okay, oops, I gotta do one of these. Oh, hello. Okay, so I'm back and thank you. Nice job, wonderful. Okay, so again, moving right along. It is the intake team from CARS, Connect the Dots. Dana, are you out there?
I am out there. Hold on one second. I'll share my screen.
Because I know I got my PowerPoint from you.
So
Dana's
pick on me. No, I'm just.
Dana's gonna share her screen and then we're gonna take turns presenting because we took this group thing like very literally.
All right.
Okay. So good afternoon, everybody. My name is Lisa Kazmarek. I'm on the intake team. Our project, our NIATEX project was called Connect the Dots. Really the entire intake team took part in this NIATEX project. Regina Lester and I were the ones that kind of co-led the project, and then Dana Blake was in charge of all the data. Okay, so our aim. So, as you all may know or may not, the people on the intake team, what we do is we get referrals and we do assessments, and then we make recommendations based on level of care. So what we were seeing is that once we met with the person and did all the paperwork and staffed it and put them on the wait list for services, we're seeing that people were not getting connected to the agency for many different reasons. A lot of it had to do with demographics. The agency maybe didn't have the correct phone number, or, way to get a hold of them. Some clients, you need to call mom to get a hold of the client. So, and without communication, things were getting kind of stuck and people weren't getting services quickly. So we wanted to improve the process and the communication between the intake team and the agencies so more consumers would be connected to services. Okay, and so our process was this. Once we put somebody on the wait list at our clinical staffing meeting, then David, who is the service manager for TCM, she sends us an email stating what agency that they were assigned to. So once we get that email, we had this very this process. Everyone did it exactly the same so that we knew our data would be accurate. So what we would do is, upon receiving that email from David, we would call the client, ask if they're still interested in services, because sometimes people change their mind, as we all know. And so if they were still interested in services, then we would provide them with the agency's name and contact information so they knew and had a heads up of who would be calling. And if they didn't get a call, they knew, they had the number to call themselves. We also confirmed their contact information. We let them know the assigned agency will be reaching out within a week or so they kind of have an idea of when they're going to be expecting a call. And then if we couldn't reach the client, we were leaving a voicemail with the agency's information. So obviously, if they said they weren't interested in services, we staffed to close it. So once we connected with the client, then we sent an email to the agency with their name, most current phone number, most current address, any collateral contacts, and making sure that the release of information was scanned into their chart, adding any pertinent information, special requests. As I stated before, sometimes, you have to go through a different person. Maybe you need to call the case manager to at a housing placement or a mom or cousin or something to get in touch with them. And then we would let the agency know the outcome of our phone call with the client, and then CC the referent, if applicable, on the email. So we decided to implement this change between the dates of June 1st, 2021 and June 30th, 2021.
And so this is the data that we collected. We collected the month before the intervention and then the month of the intervention. So in May, we had 136 referrals, and 8 of those referrals that we connected to services didn't get connected. And in June, we had 122 referrals and 6 didn't get connected. So you saw a decrease in people that didn't get connected. And I think the big one to point out is we saw a decrease in the number of people that didn't get connected due to no contact. We had 4 in May that weren't able to connect due to no contact, like unable to locate them or anything like that. And in June, we actually only had 1. So I think that communication really improved. I think the numbers also could have been higher if we didn't choose to look at the data for the month before, because those referrals that we got maybe towards the end of the May that we were connecting in June, I think we automatically started doing that process with some of those referrals. So we probably had better outcomes, I think, in May than maybe we would have had if we looked at the data at a different time. But this shows you all the programs we connected to, how many people we connected it to, who we closed, and then the ones that didn't connect.
Okay, so our next step is basically to continue with connecting the dots. We were successful in this. We're going to implement the change, continue with the steps, providing contact information, collateral contacts, status updates. And then we will continue to collect data to see if this is a continued success and make any changes as needed. If we need to tweak something, change it up. And then I think very important is to get feedback from our providers. And the impact that this had was increased percentage rate of providers connecting with clients in the community, decrease the number of discharges due to no contact or unable to locate. We found that clients felt more comfortable with transitioning to the new provider because they were made aware of in advance. The process was explained to clients. We also confirmed if they were still interested or not. Like Lisa said, sometimes, you know, things change. Maybe they got connected to treatment or feel like they don't need services anymore. And the provider information was given to our clients so that they can reach out. Sometimes our clients, we do find, are anxious and are waiting on the call, so they want to reach out. Most importantly was communication is key. This project opened up lines of communication between the providers and our intake team coordinators. We noticed increased status updates on clients. Our providers now had direct ways of contacting coordinators who handle the case, which made the transition easier to consult with coordinators. If they had further trouble with locating clients or even issues with engagement, we're able to step in and say, hey, you know, maybe you should try this or that. Maybe we have another way of contacting. So all in all, we just, you know, we're working as a team. We're all in this together, and our main goal is to make sure that clients are getting connected to providers and providers are getting connected to clients. And that's it.
Great job, intake team. So, okay, that was wonderful. And for time purposes, we are going to just keep on moving on down our list. We're going to move to St. Charles, easy on down the road. I believe Mandy has this one, the PowerPoint. Are you with us?
Hear me?
Yes, hi.
Hi, can everyone see the PowerPoint okay?
Yep, it just popped up.
Okay. Let's get to the first slide. Oh my goodness. Okay, so my name is Mandy Bebo. I am the Performance and Quality Improvement Manager at St. Charles Youth and Family Services. So I am really excited about this first slide, so I'm praying that this works. So we added a little snippet. The name of our project is Ease On Down the Road. Let's see if this will work.
Do you need to add sound, Mandy?
Okay, so what we did is we focused our program with a recovery support coordination program, which was, we had it previously, but it was kind of reintroduced and new to us in July of 2019. RSC, again, recovery support coordination, is a strength-based case management model that provides individualized plan of care to be developed for clients. And so the main purpose behind the RSC program is to assist clients establishing their own path to recovery and ensure clients' well-being, their overall well-being. And the program is designed to provide information and prevention, education, and training. Why we picked this particular program was they were identified to be part of the NITEX project because they were a newer program to St. Charles. We had just experienced a little bit of turnover with staff, with management, and so we thought this would be a great time to utilize the NITEX Change Project. So what we did, we started this back in February, March. I, with the RSC team, completed the Compass Ease survey. And the Compass Ease is designed to help programs develop welcoming services and help individuals and families with co-occurring issues. So what we did is throughout the process of doing the Compass Ease survey, what the results indicated were the RSC staff wanted additional support with resources focused on treatment, recovery, programming, etc. So they really wanted to feel more comfortable with community-based services, obviously for themselves, and to provide that knowledge to the clients that they're serving. So what we did is, following the Compass E's and indicating our focused area, we had several meetings just with the RSC team to identify what would be most helpful for them. And then I opened it up to staff in all parts of the agency to develop our resource guide. So we had several meetings. We initially focused on specific areas. So we kind of started with housing, that's a huge one, and then went to mental health, employment, legal, etc. And so a resource guide was developed, and it was, as it was updated, obviously on a continual basis, it was continually shared with staff. The impact that we wanted to see was that staff have access to abundant community resources in one centralized location, that staff are knowledgeable about resources available for clients, and that clients are able to receive that support, education, and resources. So what's really interesting and that isn't reflected in on this PowerPoint is sitting in on those meetings. It took a little bit to obviously to get staff in all parts of the agency to get together, obviously with schedules. I sent out a survey following the resource guide, and 80% of staff felt the resource guide was easily accessible, and 100% of staff felt the guide was relevant to the population they serve. And when I say staff, I opened it up to not only the RSC team, but other staff that participated in the meetings. But what wasn't captured in those results were some of the conversations that took place where staff would say, well, I didn't open up the resource guide, or I didn't use it because I didn't have my phone, I didn't have access, or I didn't have the time. But what they did really gain a lot of kind of spark with was having those general meetings and kind of having those in-person staffings. And so what we decided to do was adapt. We're going to continue to utilize a resource guide that's updated and shared, but we're also taking that and incorporate staffings for additional support. So sometimes you can't pick up on those nuances within a spreadsheet or within a guide of, hey, call this centralized housing resource and connect with this person. Don't call that main number, call that cell phone number. So just as an example, that's what we thought was most helpful. And that is the end of my show.
Great show. Just make sure to unshare your screen. You did a great job. Thank you so much, St. Charles. And we will move on to Jackie Cram, the CSP program. Let's make some plans. And so, do you know how to unshare your screen? Mandy, there you go. You did it. Great.
Okay, good.
Yeah, it's perfect. Okay, thank you so much. Good job.
Okay, so can you all see that?
It's coming, Jackie. There, you got it.
Okay. Perfect. All right, so I'm Jackie Cram, the service manager for the CSP program with CARS, and my project is Let's Make Some Plans. So the team that I worked with is myself, Stephanie Bouchain, who's the admin coordinator who works with CSP, Lynn Shaw, the crisis planning specialist with the mobile team, and then all of the clinical coordinators within the CSP network. And the aim of the project was to increase the number of active BHD crisis plans for clients by 25% in the CSP program. And so the reason I chose crisis plans was that I had been hearing here and there from the crisis mobile team that folks that were high utilizers of the services, some of them didn't have plans on file, and also just the knowledge that the presence of a crisis plan can reduce the utilization of crisis services and inform the treatment team as to how to proceed in the event of a crisis with a client. Okay, so the change, the timeline was from February 4th to September 30th, 2021. And what we did was put into place education around the BHD crisis plan, and that was provided by Lynn Shaw, who is the crisis planning specialist with the mobile team. So she came to our operations meeting, gave a presentation, and then in addition to that, provided ongoing support to the network as needed, so people could reach out for assistance. And then the other piece that I did was just provide reminders via email, as well as have open discussion at every one of the operations meeting during that time frame about crisis plans, just to see if people had questions or needed assistance. So this leads us to the outcomes. So the data, this was a new report that had appeared in Avatar. And so on February 4th, the data that I got, it actually included both final plans that were set to final and plans that were in draft still. And so unfortunately, what I did at that time was I took the number of all of those instead of just the ones that were final. So this was a lesson that I learned. When I went to get the final data, I realized what I had done there. But things that I noticed along the way with this project that were super great is that it, got people talking about the crisis plans, really focusing on making sure that those crisis plans are in the client's words. And then I have been getting feedback from the crisis mobile team that, when these lists, they're looking at folks that are high utilizers, they're noticing that there are more crisis plans within the system. So that's really great all around. And so I guess I am going to be adapting and adopting. So I'll be continuing to monitor the amount of crisis plans that are on file, but doing that just by looking at only the final ones. And that is my project. Thank you.
Wonderful job, Jackie. Thank you so much for sharing. And whenever you're done, you can unshare your screen and I'll move on to the buds of MC3 from APC.
Hey there, I'm JJ Bell with APC.
JJ, do you need help sharing your screen?
I don't think so.
Okay.
You got it there?
Yep, got it.
All right. So, what we have for you today is we call it Buds of MC3. This is kind of a maintenance project coming out of our previous project, MC3, which we were looking at if everybody in our agency was able to list what the MC3 values were. So, within our agency, we have 6 different departments and administration. So whoever answered these surveys is the data that we used. And so we started based on the previous project of what were the lowest known MC3 values, and those are the first ones that we started to provide information to individuals on. So what we decided we wanted to do is not only to have staff name them, but we want staff to be able to demonstrate these values throughout the work that they do. So we did have a goal of getting at least 90% of our staff to be able to increase the utilization of all the MC3 values. We took a 45% baseline based upon the data that we had gathered on the original survey submitted for this project. So as you can see, 45% of respondents utilized co-occurring strategies in the initial survey, followed by additional focus on each value. So our target goal is by increasing the ability for staff to demonstrate MC3 values will positively impact those we serve and hopefully increase recovery. So we're more focused on internally, do we know the things that we're promoting? Do we understand these values that we talk so highly of? So what we decided to do is we started to submit these surveys, and we provided education through staff meetings about each of these values as we were preparing to do the surveys. So as you see, after the second one that we did with co-occurring, we definitely met and exceeded our goal. And as we move forward with each one of the values, each one of the respondents you know, we had 100% that, you know, staff was able to demonstrate what these values were throughout the course of the work that we do. So what we did is, again, the initial survey identified the knowledge of each value, and then each department talked about it during staff meetings. And then the survey went out to test the knowledge of the value. So what we had learned is that throughout the leadership and supervisors focusing on values by reviewing the MC3 shadowing checklist that came about. It was particularly developed last year through our intern supervision. And we provided that to all the staff then in providing some examples of what demonstrating these values were. And so by doing this, we found that that was helpful in identifying what each of these values were in practice. Now, because of the surveys provided examples how to demonstrate the values, staff realized that they were already actively utilizing the MC3 values more often than they thought. And so, I don't know if you noticed, but on the previous slide, we were showing that we doubled up on some of the values because we felt that they kind of went together. And now that you know, we're continuing on and we're having such success in this, what we're doing is we're going to be grouping more of the values together so we can complete the project, and we'll figure out where we're going to go from there. So that is what we have.
Great job, JJ. Thank you so much for sharing. And I just want to state that we are running out of time in this meeting. It goes usually till 3:30. We have about 5 projects left. And so I'm going to encourage you all to stay because they are wonderful projects to hear about. But I am going to put the certificate of attendance into the comments section now, only because I know that some of you cannot stay. And so I'm going to do that. And then we'll move on to Word of Hope Ministries, Building Bridges of Hope. Do you need help sharing your screen?
Would you navigate for me, please, Amy? I can just make this a really quick presentation.
Okay.
Okay.
Your presentation is Building Bridges of Hope. Let's see if
yes.
Let's find that first.
All right.
All right. And
okay, so good afternoon, everybody. I'll try to make this really quick. So our project was really designed by both myself and Mr. Robert Walker, who is our employment specialist. And if you can go to the next slide, Amy, please. So basically, Word of Hope, we provide a wide range of services ranging from healthcare to employment. And one of the things that we've been trying to focus on internally is how do we do a better job of connecting clients to various services within our agency. And so one of the things we decided to do was to start with our employment program and clients who come through our ATODA program. And so our project aim was to link clients who completed our program, the ATODA program, to employment opportunities offered through our work readiness program, but also to evaluate their successful transition into a different job. So a lot of the people who come in, what happens is that either they've been unemployed for a long time, or they're just being released from incarceration, or they've just been out of work. And so we have a lot of collaborations with other employment agencies. And so more often than not, we have more connections for jobs than we have people. Next. Slide, please. So that was our goal. So one of the things that we're doing is that our initial step involves coordinating our services and tracking the number of referrals from our ATDOA program to employment. And then after Mr. Walker gets that information, he works with a client to help them with anything from resume building to interviewing for a job if needed, teaching just some soft skills and sometimes some hard skills. Then once the client has been interviewed and placed in a job, what we are trying to do and what we've started doing, because we got our first couple of people who are in the beginning process, is that we follow up within the first 30 days of hire, not only with the client, but also with the employer in terms of, the feedback of their experience, whether it's being the employee who's working or the employer who's getting a new employee, to see if it's been a good match. Next screen, please. So what we decided to do was, at 3 phases of the process, 30 days, 60 days, and 90 days, we've created a survey, bidirectional survey, in which the employee gives us feedback in terms of their experience, but then also the supervisor gives us feedback as well. So some of the examples from the employee side is, I feel I received support from my supervisor in learning my job, or I obtained appropriate training to do my job. The intent of getting that information is, if that person feels like they're not getting what they need, we want to be able to intervene and work with them to help them advocate, and then sometimes mediate the process if they don't feel comfortable doing it, with the employer, to figure out how they can get their support so that they can stay on after their probationary period. From the supervisor's perspective, they are then asked questions like, the employee asks questions when he or she needs support. The employee shows up on time and is ready to work. So then if they have issues, we then can work with the employee and say, hey, what's going on at the job? How do you like it? Are there challenges? Without coming from an accusatory perspective, but figuring out how to alleviate any challenges that they may be experiencing so that we see success on both sides. Next slide, please. So as I stated before, the evaluation process happens at the hiring process, 60 days, and then 90 days. Because what we want to see is that, when a person gets a job, we want them to feel like they're being successful. We want them to continue in that job. And we have had in the past happen where a person's been with one of the agencies we work with on employment. We don't find out until after they leave that there's been a challenge. And so what we want to do is start at the onset and figure out, how do we be a good partner, not only to the employer, but to the employee as well, to make sure that it's a good link, a good collaboration, so that we can continue that process moving forward. So as I indicated, we are at the beginning stage of this process of collecting data. We've gotten data from, well, we're not quite into the first 30 days, but we've sent out the surveys. We're waiting for feedback. And then as we get new people coming in and finishing the ATODA program, we're sending them through. And so hopefully we'll have some data to report the next time around. I think that's the last slide.
Yep.
You
did it.
That's it.
You did it.
Yay!
Yeah, and you were right. It was quick, and you had some feedback too, and you just kept rolling right on through. It was extremely impressive.
Thank you.
You did a great job. Thank you so much.
Thank you.
Okay, I'm going to unshare my screen so I can come back to you all. Okay, so now be sure to mute your mics, and we have 4 presentations left. We'll roll on through to the next one. It is Milwaukee Mental Health Associates, person-centered RPOCs.
Hello.
Hello.
I'm just going to say hi with my camera on, and then I'm going to turn it off because I don't want to watch myself. I am Chris Shrimkowski. I'm a clinical coordinator at Milwaukee Mental Health Associates, CSP North. And I do not see my, you're going to put up my.
Do you need
Yes,
help?
I would like you to, if you would.
Okay. Okay.
I like people and animals. I do not like electronics whatsoever.
Okay, let's go.
Yay. There it is. So our project was on person-centered, we call them RPOCs, and I did plan to tell everyone who doesn't use that particular terminology that an RPOC is a recovery plan of care. And this is the plan that defines the issues or the challenges that are going to be addressed in treatment. We work with persons with severe and persistent mental illness, and the methods by which the team will address the issues and provide the client's support. So when we're developing the recovery plan of care, we're supposed to be kind of sitting down with the client and deciding what they want to work on during this 6-month period, and how are we best going to be able to support those goals. So then in terms of person-centered care, it is of course an MC3 core value. And the kind of the meat that we use to define what person-centered planning would look like came directly from the Wisconsin Department of Health Services. There is a training on there with regards to person-centered planning. And we decided that what we're going to actually measure then are these 4 things that I have up. Did the client feel that they had input into all the parts of their recovery plan of care and the process by which it was developed? 2, did it accurately reflect the client's desires? So we'll ask them that too. 3, the goals and interventions were chosen collaboratively, even the interventions. How are we going to help you? And 4, it was supportive and non-judgmental, meaning both the process and the actual product, when it got written, sounds supportive and non-judgmental to the client. So I want to highlight just really quickly this little paragraph here about completion of our person-centered planning online training is the first step in learning this way of working, developing a skillful person-centered planning practice with integration into daily work requires ongoing learning, supervision, direct observation of practice, and performance-based feedback. So that's always the sticking point, right? It's also where the rubber meets the road. We can spend many, many hours in training, and what we actually get out of it in terms of the quality of our product, if we don't do these things too, the ongoing learning, supervision, direct observation, and performance-based feedback, it's only going to be as good as the individual person who took the training in the first place in terms of how much did they remember, and then how much did they actually apply to their practice. And so it can be kind of patchwork-like. You can move to slide 2 for me, please. So after taking a measurement of how folks felt about those measures of person-centered planning, the next step is and having the staff also obviously watch that particular 2-hour training on person-centered planning from the state of Wisconsin, we wanted to take it the step further, ongoing learning, by training alignment of person-centered planning philosophy and process with the actual RPOC sections that we use here in Milwaukee County in Avatar. So I put up for you the sections of the RPOC, and then on the right, you've got the process steps of doing person-centered planning as they came from that training with the state of Wisconsin. And I wanted to point out, just to put in a little plug for motivational interviewing, as I did when I did this training here for our folks at MMHA, the philosophy of person-centered planning as defined by that state training is very, very similar to the philosophy of motivational interviewing. So if you're working on your MI skills, you've already come a long way in terms of being able to implement this into your practice. But the other piece that I wanted to highlight here is that we kind of took examples, very specific descriptions of CSP consumers that were not known to the folks that were actually taking the training, and gave them and worked through the entire RPOC writing, practicing on writing, how can we talk about this person's strengths? How can we talk about their barriers in a way that won't be insulting, harmful, make that person want to shy away from this whole process, things like that. So we created a whole separate 3-hour training going through all of those sections and learning to apply the person-centered principles to each of those sections of the RPAC. Am I missing anything? So some examples might be, just discussing how using the strengths part might be a very good way of doing engagement in that session of sitting and talking to the person about what they want in their RPAC. The most important thing that they have to come out of this with is that they really have to have the planning with the person in the first place prior to writing anything down on paper. You can do the next slide for me, please. So then we also want to, in an ongoing way, teach the case managers how to bring the client into that recovery planning of care process. And these things that are highlighted on the right come directly from the additional training that we developed. Just teaching people to plan for actually talking to that person a good, month in advance of when they feel like they need to turn that in. Scheduling a meeting in advance so that everyone who might actually be on that person's treatment team has the time to say whether or not they can make that particular time and have as many people providing support as they can. And then using the skills, these are the skills that came from the training on the state website. Listening, asking, affirming, informing with permission, and supporting autonomy, once again, looks very much like motivational interviewing. Using those skills to evoke authentic participation from your client. And then using that event to, affirm the person's accomplishments. And then you can elicit their ideas by talking about what's happened at, a decent amount of length in the last 6 months. And that prepares them to give you more input into what they might really want to work on for goals and prioritize what's going to be their objective for this one. And then also some specifics, also pretty much from MI, we want to teach folks to have an RPAC meeting with the person that includes some basic measurable things, like at least 2 statements asserting your support for the client's autonomy, just reminding them, I'm the facilitator, note taker of this process. This plan is yours, and it's important that you set the direction we're going to take for the next 6 months. This is one example. Move to the next one, please. So then step 4 is what they kind of said at the top from the state too, it requires supervision to do an actual implementation of a best practice or an evidence-based practice. So what we're implementing is in our supervision with the folks in the CSP, 2 different pieces. The in-person skills at first, we're going to have the supervisors, modeling, training the staff on how to do a person-centered recovery plan of care meeting with that person and demonstrating those specific skills that we're going to be looking for. So these are some examples. And then after modeling, we want to have the supervisor observe the case manager facilitating an RPAC meeting without too much help, making sure that they can actually demonstrate those skills so we can then take that back to supervision and help reinforce it if we can. Then the other piece is spending time in our individual supervision, also editing and sometimes side-by-side writing an RPAC, focusing on that philosophy and completion of all the steps in the process, and making sure that the client's voice is heard in all those different sections of the RPAC. Next one. Next one, please. So then finally, after making sure that everyone has taken both trainings and had at least a couple of RPACs reviewed in their supervision with their their clinical coordinator and done the in-person RPOC meetings, we'll do the second survey and ask the clients the same questions. You know, to what degree did you feel you had inputs in all part of the RPOC process? Were your desires, you know, reflected in the RPOC? Were your goals, objectives, and interventions selected collaboratively, which they should have been if we asked, what can we do to help you? And then whether the process and the meetings and the RPOC as it is written actually feel supportive and non-judgmental to the person. So if we decided that if the scores on these measures are at least 20% better, we will adopt the change. I think we're pretty much going to adopt the change anyway, at least for the CSP. And then, you know, we can attempt a modification for the other programs. It's a little bit more difficult. Folks in CCS will know because you can't write your own interventions. They have to come from a menu, which is why we decided to use the CSP first as our test group. So that is it. Thank you very much.
All right, thank you so much. I'm going to move on to the next one right away. We have M&S, Bounce Forward to Wellness.
Hello, hello.
Hello, hello. Do you need?
I need you to show my screen. I would probably mess up something if I tried to do it myself.
Okay. I'm trying to find, you wanted to edit, so I put the new one in here for you.
Oh, thank you.
There you go.
This can go to the next slide. My name is Brenda King. I work with M&S Clinical Services. Our survey was conducted at M&S Clinical Services to ensure that employees were practicing self-care strategies during the COVID pandemic, COVID-19 pandemic. Our aim or our goal was to ensure that each employee felt supported in the effort to maintain safety and wellness. We all know what kind of atmospheric pull COVID-19 has had on everybody. So we wanted to make sure that we were okay as employees, as coworkers. Next slide, please. Next slide.
Yeah, it's doing its thing, what it does.
Michelle Corbett helped me develop a wellness survey, and it was for the employees. And what the questions entailed, I'm able to effectively switch off from work to make time for rest. I know how and where to raise concerns I have in relation to my own or colleagues' well-being during this time. We enjoy a camaraderie and have found meaningful ways to stay connected as colleagues in the current environment. I can see how the work I am doing is making a positive difference at my company. I generally feel positive towards work at my company. I feel productive at this time. And during these challenging times, I feel able to bounce back as quickly as I normally would. And recently, my stress levels have felt manageable. My manager is checking in regularly enough on how I am doing. On our outcome, there were several areas of discussion at 3 different points, like once a month, going into the end of the survey results. And one of in meeting with upper management, which is Mr. Fossey and the supervisor at that time and HR, was on Thursdays employees could work from home. Now that didn't pan out because people started coming to the door. knocking on the door for services to have assessments completed, and we would inform them we're not seeing anyone in the facility, but you could call. So that didn't work like that, so we stayed in. However, there were other areas that were addressed to make it more comfortable. Chairs and other physical comforts with regard to office supplies can be ordered for each employee that needs it. We ended up doing some chairs and things that were more comfortable that made it easier. Our personal days being increased from 3 to 5 per cycle of time allotment, and that was contingent on as we are at fee for service. Oh, next slide, please. As we are at fee for service. So that it didn't permit the expanding of days. However, in just that discussion, when if you have a medical appointment to attend, or if you have something to go and take care of, picking up the child from school, taking them to the person that's going to care for them until you get off work. We were allowed to do those things without having to take that time off, but being allowed that time during the day to be able to go and do it. And educational allowances for any classes, any in services that we could obtain that are geared toward wellness. Next slide, please. In our survey outcome, we have one employee who is allowed to continuously work from home. As I forested, we have obtained chairs that are ergonomically sufficient for those employees who have requested. I, for one, did. Fee-for-service revenue availability not permitted to increase the number of personal days. However, as I forestated, the time is allotted to do so without the employee being penalized. And we still have the option for assistance with payment for any wellness classes, or if an employee wanted to, say, obtain a gym membership, M&S will assist with payment for that. And there you have it.
Well done. Thank you so much for sharing, M&S. And just FYI, we have 2 left. I'm going to come back to you all right now. Oh, if I can, there we go. I'm going to come back to you all right now. And we have 2 left. And like I said before, remember, if you cannot stay, I went ahead and put that certificate of attendance in the comments section. If you need to go, that's okay. We do have 2 more projects, so I encourage you to stay so that you can hear all the lovely projects. And the next project that we have is improving the resident therapy attendance rate. Tanya, I think this is you.
Yeah, but it's going to be Tori Johnson from Sankofa House.
Okay, that's perfect.
How you
so
doing
much.
today?
Good.
So,
and you did need help sharing screen, correct?
Yes.
Okay. Let's see here. There you go.
Okay, thank you. So our goal here at Sankofa House was one of our main goals was to improve the residents' therapy attendance, the rate of them attending weekly to see their therapist. So on the next page, you can turn.
Oh, it's doing its thing that it does. I don't know why it keeps doing that.
Well, at least it gives me a chance to breathe.
Yeah, you just breathe. You're doing just fine.
Okay. So in May of 2021, our team saw an opportunity to improve the resident therapy attendance rate. The 12-month prior to May 2021, we saw an attendance rate of 56.98%. So we set the following goals to increase the resident counseling attendance rate. Our big aim was 90% of the residents will attend a weekly one-on-one therapy. I'm on page 3 now. So what we did do was we established a therapy tracker to collect data in real time. We scheduled contacts with the Sankofa program manager, which is myself, the clinic manager, to discuss therapy, attendance, and misses, and to improve Sankofa team communication, importance, and the importance of the therapy. We started additional group services to increase and improve services at Sankofa and increase access to attendance. And if you could go to the graphs.
One more.
I think that's 5 on 5. It's 5, that one. So then, as you see, in May and prior, our attendance record for therapy was hitting at like 56.98%. And then June, we went up to 91%. In July, we dropped down a little bit to 87%. In August, we was back up to 96%. And in September, we hit 89%. And sometimes the attendance is based on the stay of our residents. So we got some residents that might be here today and gone tomorrow. So then the next slide is the Sankofa resident therapy attendance. So in May, and prior to that, we was at 57%. So far, well, we in October now. From June to September, we hit 91%. So on the last slide is our future plans on keeping this going at a beautiful rate is to adopt all interventions because they worked. We will maintain and huddle around the tracker, continue our community and one-on-one discussions that we have every day regarding therapy, and continue providing groups. So that's about it for Sankofa.
Wow. Well, that was short and sweet. Thank you so much. Well done. And somebody has just requested the certificate of attendance again. So let me plunk that in there.
I did it.
You did it? Okay, wonderful. Thank you. Was that Jackie?
Sure was.
Okay, thank you, Jackie. Okay, we have one more left, and I think it is UCC, Making Stronger Connections. I hope I'm saying that correctly because it's with an X.
Yeah, hi, can you hear me okay?
Yes.
Yeah, so that's Conexiones. UCC UCC serves a lot of Spanish speaking clients, so we normally like to incorporate a little Spanish in our titles. So that's Making Stronger Conexiones, connections, same thing. That's the name of our project. You can and if you could share your screen, Amy, that would be great.
All righty. Let me just, oops, we got to get out of here though first. Here we go. Okay, let's find it. Okay. Can you all see that?
Yes, I can. Okay, great. So yeah, go ahead and go to the second slide, please. So UCC knew right off the bat, oh, and you can just press next a bunch of that stuff will load. I have little transitions, yeah. So we knew right off the bat that we wanted to focus on telehealth, virtual sessions. It was a really major adjustment for our clinicians and clients to move virtually. So we knew right away that we wanted to focus on that. Our aim statement was that we wanted to start with improving clinicians' skills and confidence related to hosting virtual and individual group sessions on WebEx. So really quickly, what we did was we just collected some baseline data. We asked our clinicians to fill out a survey on their confidence and knowledge of WebEx. We looked at the data and decided that the clinicians needed a training on how to host engaging WebEx groups and individual sessions. So, you know, getting away from just lecture style stuff like that. And we wanted to show them how to make it more engaging. We administered a little post-training quiz just to lock in that new information. And then we gave them about a month to practice and use the new things that they learned in their training. And then we sent out a post survey. We analyzed the post survey data and started what I am calling our Change Project 1.5, because we didn't really get to flesh it out as much, which I'll touch on in a second. Next slide, please. So just some quick data we can fly through. We asked, rate your ability to engage clients during group therapy sessions on WebEx. And we saw, kind of interestingly, we saw some people move down from excellent to just good or maybe even fair, which we thought was kind of interesting, but honest results. But overall, we have people all saying fair and good. And then we also asked them to rate their confidence with a number of different functions on WebEx. We were hoping to see less of the blue and red bars and more of the green and purple bars in our post-survey results, which we do see. We do see, if you can see that little green arrow down at the bottom there, we did see that a lot of clinicians were actually reporting for poor confidence with presenting video specifically. And I will touch on that a little bit later. You can go to the next slide, please. And then some more data that we see here. Something that was nice to see was that overall satisfaction with hosting these virtual sessions went up. A lot of our clinicians went from very dissatisfied and dissatisfied up to neutral and satisfied, which is just nice to see. But then this is where we kind of got into our change project 1.5 that I'm calling it, because we did get, we saw this post survey and they were definitely reporting to us that all of this is really nice. Breakout sessions and polls and WebEx are all really fun and nice, but if the client is not actually using the app and logging on that way, if they're calling in, they can't participate in any of that, and they're really struggling with connecting with clients, not seeing their faces, and things along those lines. So we started, you can go to the next slide, please. So we did start another change cycle. We said, okay, we've addressed the clinicians are feeling a little more confident in running these. Now we need to work with our clients and making sure that they're actually, logging in through the app, have cameras, etc. So we created this little how to download WebEx app handout that every single one of our clients received. We had a Spanish version as well. And it just had a QR code and, really step-by-step how to download the app so that the clinicians could do these engaging techniques that they just learned. I'm calling it 1.5 because we started doing this. We transitioned to just doing clients intakes in person so that they can sign consent forms, learn how to download WebEx and all that good stuff. And then we moved to virtual groups and individuals. Shortly after we created this form, we did move back to all in person. We're very lucky to be able to have the space to be COVID friendly, and it just kind of worked for our population a little better to go in person. So next slide, please. So just to wrap it up, and you can hit next a couple of times because there's some transition. Yes, thank you. Yeah, so basically the goal met. I think, yeah, sort of. We definitely, for the time being, increased some confidence and increased overall satisfaction with our clinicians. Of course, the challenge was that the time constraint happened where we moved back to in person and we didn't really have time to keep adapting or abandoning. So we had some successes and there was definitely some room for further improvement. However, we are back to in person, which is great and really good for our clients. So for the time being, though, this project really did, impact our clinicians a lot. And a lot of them reached out to me and said, that was so helpful and thank you. It's helped so much. So that is UCC's project, and thanks for listening.
Yeah, thank you so much. And I think that is our last one here. I'll come back to you guys here. I think that is our last project, unless I'm missing anybody. Am I missing anybody? Okay, so I want to take a moment to thank the people that participated today because I am just flabbergasted at how well everybody did with the technology and the flow. I realized that we went over, but the projects were amazing. Thank you so much for participating in the NIATech Storyboard this year. This was the first time we've done virtual, and I really feel like it went well. A little bit long, but that's okay because we got, it's a good problem to have. We had tons of projects, so that's great. So I want to say thank you for coming. If you need a certificate of attendance, it's in the comment box. And I hope that you all have a wonderful rest of your evening. And those of you who are part of the NITEX Collaborative, we'll see you at the next meeting.
Amy, just so you know, your last words were silent. So I don't know if that was just me, but it was, I couldn't hear you.
What did you miss out on?
I heard
Yeah,
her.
I still can't hear you.
I hear you, Amy.
Oh, okay, good.
I can
No,
hear
we
you,
can't.
Amy.
I hear you. Hear me? Just Janet cannot hear me?
Well, now I can hear you.
Oh. Great job, Amy. Great job, team.
Great job, everybody. I didn't.
Oh my God, that was so awesome. I learned so much.
A lot of really good projects.
A lot of really good projects. A lot of really good resources for all of us, and lessons learned, and just like awesome. Although I have to say, I remarked that I really miss going around getting freebies during